Welcome, Robert. I've been asked by the FAANS to do what they call the FAANS Leaders in Neurosurgery. And this is an opportunity for us to discuss your legacy in neurosurgery and for me to ask you some probing questions. As a way of introduction, I thought what I would do is read the intro that I gave to you when you won the Cushing Award 2 years ago at the FAANS. Everybody knows you, but for those who may not know everything about you, this will fill some of those gaps.
Doesn't that mean then you no longer need to ask me any questions since that takes care of it?
I knew you would look for a way out.
Yeah.
Okay, here we go. It's my honor and privilege to introduce the winner of the Cushing Award for Technical Excellence and Innovation in Neurosurgery, Robert F. Spetzler. He defined technical excellence for the last 30 years and made seminal contributions to neurosurgery unlike any other neurosurgeon. He completed his neurosurgical residency at the University of California at San Francisco under Charlie Wilson. It was there that Dr. Spetzler developed an interest in neurovascular surgery and a commitment to academic neurosurgery. Before finishing his residency, he had already published 15 articles in refereed journals, of which he was the first author on 8. During this time, he had also helped edit 2 books and made almost 20 presentations at national and international meetings. He received the annual Resident Award at the 27th annual meeting of the Congress of Neurological Surgeons. After completing his residency in 1977, Dr. Spetzler joined the Department of Neurosurgery at Case Western Reserve University in Cleveland, Ohio, as assistant professor. In 1980, he received his first major grant from NIH, developing a primate model of stroke. In 1981, he was promoted to associate professor and held that appointment until 1983. In 1983, Dr. Spetzler assumed the J. N. Harbour Chair of Neurological Surgery at Barrow Neurological Institute in Phoenix, Arizona. 2 years later, when Dr. Green retired, Dr. Spetzler became the director and later its president and CEO until his retirement in July 2017. Under Dr. Spetzler's leadership, Barrow Neurological Institute grew from primarily a regional center to an internationally recognized center of excellence that attracts both visiting healthcare professionals and patient referrals from around the world. The neurosurgical residency program became the largest and one of the most highly sought-after programs because of the diversity of clinical experience and the emphasis on technical excellence. These accomplishments underscore why Dr. Spetzler was chosen the honored guest of the Congress of Neurological Surgeons in 1994, the youngest member ever to receive this coveted honor. Among just a few of Dr. Spetzler's contributions have been the development of theories on normal perfusion pressure breakthrough and how the size of AVMs is related to their rupture, the development of a heuristic grading system for AVMs, the Spetzler-Martin grading system, advances in the surgical treatment of complex neurovascular lesions based on hypothermia, barbiturates, and cardiac arrest, the development of innovative surgical approaches for skull-base surgery, and the development of surgical techniques and entry zones for cavernous malformations in the brainstem. At retirement, Dr. Spetzler treated 6,500 aneurysms and published more than 750 articles in refereed journals, more than 200 book chapters, and edited or co-authored numerous books and atlases. This award is meant to recognize masters of technical excellence and innovation, but when one witnesses excellence firsthand, it sparks inspiration. Even more impressive than his resume of accomplishment is his legacy of inspiration. He trained over 200 residents and 50 fellows and countless observers who watched and learned from his elegant and heroic operations. I am lucky to be among those inspired who strive daily to propagate his legacy of technical excellence today. When I think about his influence on my career and all the patients that I treat, then multiply that by the hundreds of neurosurgeons he has mentored or touched in some way, his impact becomes worldwide and immeasurable. He is the rarest of neurosurgical talent, in the same rank as Cushing, Yassergill, and Drake, and neurosurgery is different today because of this one surgical master. This could not be awarded to a more impactful and deserving neurosurgeon.
Thank you, Michael. It sort of when I listen to that, I don't quite know who you're talking about, but I'm happy to take credit, even if it's undeserved.
Well, it's very well deserved. So that's just so that everybody level sets and knows all that you've contributed. And I think the reason we're here is because you are one of those recognized leaders of important legacy. So I wanted to just start by talking about cardiac standstill, because when I think about when I was entering neurosurgery and learning about this field, that sort of really caught my attention. And I think it's probably safe to say that the procedure put the BNI on the map. And I wanted just to talk to you a little bit about where that idea came from and how you felt when you did those procedures for the first time and beyond.
Yeah. Well, I'm not the one to originate that procedure. It was really Silverberg at Stanford that brought this to the neurosurgical world. We, however, did a lot of research down in the laboratory on cardiac standstill with my fellow and then colleague, Dr. Sabramsky. And I think we refined it to the point where it was a little safer. And as I recall, our total series was 106 patients for cardiac standstill. And we reserved this procedure for aneurysms, virtually all in the posterior circulation, and all that at the time were considered unclippable unless you really were willing to accept an incredibly high risk. The beauty of that procedure, and I'm thinking there are still patients that deserve it, although they're very uncommon. And the reason is when I see some of the recurrences of the big, giant basilar artery aneurysms that have received coils over and over, and again, you see this growth. That's really where the initial treatment might have been used. But yeah, it was an exciting procedure. It was phenomenal to see somebody's temperature go down, their heart stop, the machine go on to keep the circulation going, and then stopping everything so there's absolutely no blood pressure, and finishing the job. It reminds me yesterday at a luncheon, which was called a legacy luncheon for the BNI, and I told them the story about the little girl that was run over by a big tractor in a rodeo arena. Should have obviously been dead, head squashed, but it had been plowed for a fair, so the head sunk down partially into the dirt, and so her head got squeezed. She had a big skull fracture in the bottom, had a tear in the basilar artery, and then it was tamponaded by the blood clot. And it was at the same time that we were hosting a skull-based society meeting. And when they saw the case, they all wanted to see it. And with the family's permission, we broadcasted it live to that audience of neurosurgeons. And it was only because there had been somebody standing over my shoulder with virtually every case that I felt comfortable in doing that. But that little girl survived only because of cardiac standstill, and only because we had done all this previous work with cardiac standstill to take on a case that really appeared hopeless. Mm-hmm. So there are cases that I think will come along, and you'll be the person doing them.
Yeah. Well, speaking of me doing them, when I got to San Francisco, I was excited to do the things that you taught me. And one of those things on my list was cardiac standstill. And I remember when I did my first one, it was almost an overwhelming experience, because you're in the operating room with a cardiac surgeon and his team. You're in the operating room with the neurosurgical team. You've got this inflated, enlarged anesthesia team. And you come down to this special moment where the heart stops and the circulation stops, and all eyes are on you. And it's not like it's an easy thing at that point. It's an incredible responsibility to then tackle this beast of an aneurysm. And I remember feeling this almost crushing sense of weight at those moments. And I only did 4, but they were never easy. They were all like that. And I just wondered if you could talk about, the emotions that go through your mind and body when you're in that moment.
Yeah, I felt a huge responsibility on behalf of the patient. I always have. Didn't have to be just cardiac surgery. And I think I felt that same thing, whether it was cardiac standstill or whether it was a basilar artery aneurysm that was difficult. The cardiac standstill stress was always higher, just simply because there were so many different components that all had to work together. And I remember very specifically with one of the very early cases, we were on the pump when the electricity went out. It all became dark until until it kicked back in, but for about 15, 20 minutes, the cardiac surgeon manually kept the pump going, so there was continual circulation. And fortunately, that patient actually ended up doing well. So yeah, there's a lot of stress in those situations.
Yeah, yeah. Well, the first time I heard or read your name was when I bought my Greenberg Handbook of Neurosurgery, and on the back, in one of those early editions, it had the Spetzler Martin grading system on the back. And you know, I think it's probably safe to say that for me, that's how I learned your name, and I think for many, that's how they learned your name. Can you just talk about AVMs and what it was about the AVMs that drew you? Was that something that you had an interest in, or was that just something that bears your name almost by chance?
No, not at all. It all goes back to a case that Charlie Wilson, who was my chairman, did. He did an AVM in a young woman. It was not that big, maybe 4 centimeters, 4.5 centimeters, but very high flow. And he did a beautiful job of resecting it. The patient did very well postoperatively for a few hours when she went downhill. And she ended up dying, and the post-mortem showed a lot of hemorrhagic infarction around the bed of the AVM. And it really troubled me a great deal. I'd gotten to know the patient and the family pretty well. And it came to me that when you shut off the blood flow to a high flow AVM and you suddenly change the perfusion pressure around the AVM, because water obviously flows the least resistant. It's sort of like having a river feeding a whole number of rice paddies, and then you're shutting off the river. It's going to flood the rice paddies overwhelmingly, just like you're taking somebody that's very hypotensive and you make them hypertensive. They have hypertensive breakthrough. And I believe that's what happened. That led me to spend my research year working on this with a cat model where I reversed the flow instead of the carotid artery going up. I took the other stump from the head and anastomosed it to the vein. And so there was very high flow and did all sorts of physiological measurements, which I thought sort of supported this normal perfusion pressure breakthrough theory. And I put it together and submitted it to the Congress when Dr. Wilson called me to his office, and he said, Robert, Dr. Tu just called me, and Dr. Tu is in charge of the Congress Best Resident Presentation Award, and he wonders whether you'd be willing. And I said, well, sure, I don't care. and that's how I got the Resident Award that you previously mentioned. Purely serendipity. But that is what started my interest in AVMs. I've always thought they were the most difficult lesions by far. And when Neil Martin, my first fellow, came to the BNI, we sat around and discussed as to how do you really compare series? Because if you take some with very small, easy surface AVMs and compare them to some of the deep, terrible AVMs with deep drainage, there's just no comparison. So we utilize this relatively simple paradigm by looking at all the factors that would affect this. For example, deep drainage automatically means you have part of the AVM that goes deep. That makes it much more difficult than it isn't. And that's how that system was developed. We simplified it with Dr. Ponce into a 3-grade system. You, on the other hand, expanded it to I think 10. Isn't it a 10-fold?
Six criteria instead of 3.
We both obviously have a great interest in this, and I suspect we'll probably both agree that those are the most difficult lesions that we treat.
Yeah, I couldn't agree more. And it's funny because I watched you operate for 7 years as a resident, and I could tell with some cases you really enjoyed yourself. Like when you were doing a bypass or taking out a cavernous malformation, you really seemed to enjoy it. And I remember always feeling like that was not the case with AVMs. Like it was always a hard slog. They were sort of frustrating. The bleeding wasn't always something you could control the way you'd like. And I'm curious what your thought is. Did I read you right?
You read me absolutely right. The trouble is not just getting the AVM out, but then a whole sleepless night where you're just waiting for that telephone to ring. And I can only tell you that it rang too often. And when it rang and I answered, and it was actually about a new patient in the emergency room that required hematoma evacuation, I was so relieved that it wasn't the AVM I had done that I felt badly for not being more worried about the patient we were about to take care of.
Yeah. It was always a joy for us as residents to operate with you. You're a completely dedicated mouthpiece user, which means that you've got something in your mouth and it's always hard to talk when you have that. So I distinctly remember that as a surgeon, you were fairly silent, and we would have to watch you work, which was always exciting, but we would have to kind of interpret and try and read your mind and your next moves and so forth. I'm just wondering, like, how you saw yourself as you operate. Like, do you, in those moments of silence and as you worked, like, what goes through your mind, and how do you mentally kind of get yourself in that space?
I think the successful surgeon does a number of things. One is he or she thinks about the surgery beforehand, naturally, when they're setting it up. But at night, before a big case, I would always go through, consider all the complications that could occur, and sort of in my mind decide what I would do if any one of those appeared along the way. And then during surgery, I sort of kept that in the back of my mind. But otherwise, it was really a matter of focus. It's fascinating to me. I'm sure it's also what happens in sports, any other activity where you're so focused that really the rest of the world disappears. You don't get tired, even though you've been at something 6 hours, 8 hours, in the very old days, 10 hours or 12 hours. And I think by being this prepared and that focus, you can sort of limit the complications that are otherwise inevitable.
So what made you nervous or unsettled?
AVMs, because the relief of getting it out, but then the stress of the night's worry about a telephone call.
Mm-hmm. What made you distracted in the OR?
I had a very comfortable OR. I allowed people to talk. We had, in the early days, we had lots of music. When I came in, it would be classical music. When the resident was in, and usually was rock. But then, when I asked for full attention, I got it. Because it was very limited, and only when I really needed it. And I think that made it easier on the staff. And the other thing I desperately wanted to avoid is acting out in anger. So I don't believe I really did that in the operating room ever. And that eliminated the fear for somebody suggesting something or replying to something. I think it made it an atmosphere that was comfortable for everybody.
Yeah. Hearing you talk and having this interview brings back so many memories. And I can remember one case where we were doing a saphenous vein bypass, and you had sewn in one end, and we were getting ready to tunnel the other, and the nurse did something that pulled the entire graft out from the anastomosis. And I remember there was zero anger. You said nothing, and you just went back and re-sewed it, and we were all like waiting for something to be said or done, and nothing came. And it was remarkable. And the other thing that I have come to appreciate was, like for me, I get sometimes a little distracted by what's happening in a second room, mm-hmm. and because you don't have line of sight on that. And you would, back in the day, run more than 2 rooms, and I always marvel now at how you were able to do that and juggle that sort of high wire act of so many things at once.
Yeah, that at times was very stressful. That's a good point. But I'd like to point out that when I had somebody like you in the other room, that already was a sense of comfort. And since we really did have the very best residents and the best fellows, it allowed that juggling with tolerable stress.
Yeah. So I want to ask you, I teased you about this at your Congress honored guest, about how the things you were honored for in 1994, like cardiac standstill, like transfacial surgery, have largely gone by the wayside. And I wonder, like, with the lens of time and these decades, how does that make you feel? Do you feel like that's just the natural course of things, or how have you felt about some of your signature things?
Yeah, I feel rewarded that I was able to play a role in that transition. I mean, initially, when we had skull-based meetings, it was how much anatomy we could display, how much of the head was wide open, the more the better, at a great cost to the patients. And as we got better and better, it became smaller and smaller and smaller. And to have played a role in that pathway is a reward. I'm not in the least bit sad that those big procedures have gone wayside.
I want to pivot a little bit and talk about leadership, because obviously you led the Barrow from where it began to this international premier neuroscience center. And I call that Barrow 2.0 because you had your vision when you moved from Cleveland to Phoenix. And I'm curious, like, looking back on your journey, Barrow 2.0, was that, did you achieve what you were trying to achieve?
Mm-hmm. We achieved so much more than I had ever hoped for or dreamed. I went to the BNI when John Green, my predecessor at the BNI, asked me to meet him at a Congress meeting in the room. I was interviewing for a chairmanship position at Einstein. I was offered the position. And every time I went there, it was they never invited Nancy along, and you sort of needed an armored guard to get in. A lot of intellectual, high minds that were available, which was very attractive, but the setting was very uncomfortable. So when John Green said, "Why don't you come and look at that?" They had already gone through their search pretty much, and we're down to considering offering it to somebody. And I said, sure, I'd come. I was very young. I wanted to get out of Cleveland. I was, I think, 36 years old. And I came home and I said to Nancy that, you know, Nancy, this guy in Phoenix wants me to come out and look at a job. She looked at me and said, if you go to Phoenix, you're going by yourself. She remembered going through Phoenix in July in an un-air-conditioned car and where she thought that the pavement just bubbled from the heat. But what John Green did, it was in the fall. He said, you need to bring your wife with you. Contrast that to the Einstein invitations. We came, it was a beautiful day, and introduced us to a lot of people. And we loved the West, and to make a long story short, I loved the challenge. I was sort of a happy-go-lucky guy. And since I wanted to get out of there, I went. I checked with two of my colleagues who I greatly admired. One was my chairman, Dr. Wilson, and his phrase was, you will wither in the desert. I will disappear in the desert. The other was Ben Stein, who I'd been skiing with all these times. He said, go for it. And so I went with Ben, and I went there, and to make the place, I had a couple of criteria that had to be met for me to really come. One is I had to be able to coalesce this group of neurosurgeons that I thought were worthy. I know it sounds a little egotistical, but worthy to form a group. And what they had to do is they had to commit to subspecialization. This is a big deal for somebody that does everything. Ben Stein also told me there was one of his residents was in Phoenix whose name happened to be Volker Sonntag, and he was a pivotal person in that group whose importance naturally rose and rose and rose. But that was one. And the other was that we were all going to be in one housing with this subspecialization, and we were going to concentrate on publications and presentations. I put all my energy into the residency program for the first 7 years as residency program director. And then Dr. Sonntag took that over and brought it to an incredible high, and that's really how we developed the strength of the residency program. And never looked back. It was absolutely great.
Yeah. If you think about, say, Charlie's legacy, when I think about it, it's sort of like the surgeon scientist that sort of captures his philosophy. And I think about Nick Hopkins. We talked about Nick earlier in private. His legacy was really pushing the endovascular frontier to new heights. Al Roten, it was really all about the neuroanatomy and taking an anatomical perspective into the surgical work. How would you kind of encapsulate or capture your legacy, your philosophy?
Yeah, I think I often start off a talk when I'm talking about my journey. I say there are a lot of roads to Rome. And there's, if you look at Rome from the top down, you see all these roads sort of converging in Rome. There are many, many different pathways, and they have to fit the individual. Rotan made his place. I don't think very many people remember it now. Charlie Drake made London, Ontario. I think very few people know it now. Yassergill made Zurich, and so on down the line. So it's the individual, and they all did it different ways. When I was a medical student, I went to Northwestern because Paul Busey was there. Paul Busey was at that point the neurosurgeon in the United States. He was head of Journal of Neurosurgery. He took me under his wing, and I was doing research in his lab, and before I finished medical school, he sent me to Zurich to observe Yassergill and Krahenbuhl, and it was an eye-opening to watch crane buell operate was the old way, he was very, very good. To watch Yassergill operate was the future. And so I remember one particular case where crane buell had taken out a pituitary tumor through the open skull. And then when he was done, he said, well, get Ghazi. And he treated Ghazi sort of like a junior attendant, like a diener in the operating suite, to bring in his microscope and see if he could find anything, sort of a challenge. Well, piece after piece would come out when he brought in the microscope. And so that's following Yassergill was my hope from a technical sense. Following Drake, who was such a great human being, the fact that a medical student could go up to him and sit down next to him, ask him a question, and he'd allow that. I wanted to be a combination of those two people.
Yeah. Okay. Talk a little bit about Volker. I feel like you mentioned him a minute ago, and the two of you had this incredible chemistry. I think it'd be interesting for people to hear like what he meant to you and how he pushed you.
Yeah. Well, you've got to remember that Volker was in private practice when I came, solo practice. He'd had a tough time starting his practice. He went to every emergency room, signed up at every hospital, just like a young practitioner has to do. On one of my visits to Phoenix, John Green, who saw that I was seriously considering this, but very ambivalent, invited Lynn and Volker Sonntag to a dinner. And Lynn and Nancy really hit it off. And then the next day, John Green said we should really visit their house. They were in a house where there was green grass, and coming from Cleveland, that was important. And there are two little kids running around in the house. We struck up an immediate friendship. And I think Volker's genius really comes from being a team player. He was somebody that loved a clean desk, which not abhorred is not the right word. I was incredibly jealous of every time I went over there because my desk was stacked high. But we meshed, and we both were committed to making it the best residency program we could make. And Volker, who had really not had any academic goals, etc., took it on, gave up the rest of neurosurgery to concentrate on spine, just like I gave up spine to concentrate on the head. Was prolific. He was prolific. He was a star in his own right. And so we went on vacations together every year up to Lake Powell with all the kids. We traveled around the world together, and this friendship had a direct bearing on how the residents were able to interpret life outside of just the hospital.
Yeah. You and Volker were really great athletes, and I think one of the sort of stereotypical images of the BNI was that it was a more athletic residency. Your philosophy of surgery was more like a sports and athletes mindset, and the two of you were fiercely competitive. I wonder if you could just talk about that competitiveness in your life. I think the two of you were probably two of the most competitive people I've ever met.
Oh, yeah.
And I wonder like how you see that trait in the perspective of
Yeah,
your
yeah. Dear Michael, first you got to look in the mirror if you say that.
Well,
We are.
as you say, we are your offspring, and we have inherited this pathology from you.
Yeah. Nancy and I had always done something physical. I was a swimmer in college. Nancy was a runner. Her dad was a Olympic alternate in running when it was canceled for the Second World War. So we made it part of our lifestyle. We would get up early in the morning and we jog, maybe 5 miles, 6 miles, longer on the weekend. And we had a wedding. It was Dr. Graham's wedding. I'm not sure whether you were there or not. And we were talking about doing things, and Mark Hadley was there. And if you know Mark has a big voice. And as the evening dragged on, we ended up having a challenge between the residents and the attendings for a triathlon. Curtis Dickman was the swimmer. Hadley, who was a terrific athlete from Stanford, was the runner. And was it Zabramski? Anyway, the bike, yeah, I think the biker was Zabramski. And it was me swimming, Sontag running, and I think, I don't remember exactly who was biking. But at any rate, that set up our first competition. Well, I swam, I did a reasonable job. I come out and we're looking around and no Dickman inside anywhere. Now come the stragglers, 300-pound woman waddles up the ramp. One-legged man waddles up the ramp. We're ready to set off a cannon to see where Dr. Dickman is. Finally, he comes out white as a sheet. And Dr. Hadley, who was supposed to catch up with whatever loss they'd had in speed, was ready to take off, was so far behind. He was so disgusted, he just couldn't even speak. So that's what set up a physical sort of interest among the residents and the attendings. And that developed into where we had the Olympics initially between UCLA and us, and then it ends up now in your time between the spine service and the cerebrovascular service. But the perfect weekend for us was mountain biking on the weekend, on Saturday, road biking in the morning on Sunday, and volleyball at my house in the afternoon. And there were a lot of participants, attendings or residents. And many of them speak about it years and years later as something that particularly was memorable for them.
Yeah, Henry Schroeder mentioned that yesterday.
Yeah.
Who are your heroes in sports?
I'm really not much of a hero guy for sports. It's more of what people have done, the non-professionals in sports. I avidly follow the Suns. I like them, and naturally they're top players. But it's really more the person that does it on their own. Crossing the Grand Canyon, a tradition I'm just delighted that you have continued. To me, was always a spiritual experience. I mean, going down that mile into the canyon, watching these rocks and remembering that these were created 10 million years ago, 20 million years, and so on down the line. And associated with a tough physical workout was always very special. And it was a pleasure to see so many residents and attendings and visitors from around the world join us in these sojourns. And I think it bonded us a way that you can't establish if you're just seeing each other in the hospital.
Yeah, so true, so true. And it's those bonds that form doing a tough task together are just so powerful.
Yeah.
So powerful. Well, one of the things that I've enjoyed in these last 6 years is seeing how much you've enjoyed retirement. I never expected that. I figured you would be holding on to things, wanting to be back in the OR, and I was actually, it almost led me not to take this position. But I've watched you really enjoy retirement, so I wanted to ask you a little bit about what you enjoy most.
Yeah, it's funny because I was talking with somebody that we both know yesterday who called me specifically to tell me that he is now considering retirement because he saw that I was still happy being retired. Now, I've got to go back a little bit because in order to lure you to the BNI, I promised to go on a sabbatical for 3 months. You told me it was 6 months. No, you told me it was a year, didn't you? So I compromised on 6 months. And that was, for me, absolutely perfect. So for 6 months, I still got a lot of calls. Even as I do now, I get a request for an opinion and a lot of requests for talks that sort of keep me in the loop. But for 6 months, I could concentrate on things that I love doing, but that were always squeezed by the enormous burden on time commitment for surgery. So when, at the end of that December, when I was planning on going back, I really looked in the mirror and I liked the way it was, and I'm not sure that my ego could have taken you putting your arm around my shoulder saying, Robert, it's time to get out of the operating room, which I had to do with John Green, bless his soul. Sweet, sweet man, had little brainstem strokes, but he would come into my office and tell me, Robert, the only place I'm really happy is in the operating room. He was a great gentleman, and he took it well, but we were putting patients at risks, and I've never liked that a resident would be able to do an operation on behalf of the attending if the attending wasn't better than the resident. Never liked that. So I looked in the mirror, I liked the way it was, and I think the only person that didn't want me to stop was Nancy. Just she didn't want me around quite that much, but I saw a look of relief on your face, so that made up for it.
Well, I'm pleased that I could have contributed in some way to your enjoyment of retirement.
No, I love retirement.
Yeah. What do you miss with retirement?
Really not very much, not very much. I was surprised, like Dr. Henry Schroeder, who had visited the BNI multiple times, gave a talk yesterday when you invited him for Grand Downs, and I so greatly enjoyed the presentation of his cases, which he handled in an artful manner, and I wrote him a little note afterwards how I enjoyed his artistic surgery, and he said, yeah, I learned it all at the BNI, and I think we affect people so much more than we ever recognize. And I love getting letters from patients of 20 years ago, from people from around the world, neurosurgeons who said, well, we met 25 years ago, et cetera, et cetera. We touch a lot more lives than we ever recognize. And that's a great reward. So I feel very much involved. I like the fact that it's at my pace rather than at your pace.
Yeah. I'm going to borrow a question from Reid Hoffman, who does a wonderful podcast for entrepreneurs. And one of the questions he always asks on the show is, what advice would you give your younger self if you could go back into the past and advise yourself?
I think probably I would avoid some specific instances, but I think my happy-go-lucky attitude served me well. So maybe a little more time for special people than I was able to provide. I can only tell you that when I got the Honored Guest Award last November for the second time, the thing that struck me the most and the thing that pleased me the most is when she showed that slide of where SEPI had sent out a request to all the fellows and residents as to how they saw me with one word. And then she put that up on a slide, and the size of the word represented the frequency of that. That the word kind came out, which I was surprised at, but incredibly gratified for. So in looking back, I loved my career. I was fortunate in the person that I traveled in life through. And so I've always said to the residents, there are two blessings in life: to be happy at home and to be happy at work. I had them both. Naturally, when I say that, and Nancy was there, I would always add, well, at least I was happy at work. Yeah.
Well, Robert, this has been great. It's been a privilege for me to interview you, and I will just say that you along the lines of what you were saying, you have no idea the impact you've had on so many lives. But for those of us who were so fortunate to be your residents and to be with you, you've been a role model that has changed all of our lives. I mean, Suzanne and I wouldn't have done so many things in our life had we not had the example of you and Nancy, and from buying a ski home to how you get in good habits of exercising and taking care of yourself, to the techniques in the operating room. There's just so many things that you've transmitted to me personally and my generation that are innumerable. And you've been that role model for me and for so many of us. And on behalf of all of those people, I thank you.
Very, very generous. Thank you.